Hello, everyone. My name is Dr. Neva White. I'm the Executive Director of the Fraser Family Coalition for Stroke Education and Prevention. The Fraser Family Coalition for Stroke Education and Prevention was made possible through a generous gift through the Fraser family and the Nicoletti family. This gift was bringing together both the Temple Health System and the Jefferson Health System to work together in the North Philadelphia community to bring the resources of both health systems together to work to prevent stroke in this community. We are so happy to bring the Vascular Health Initiative into this community, and we have two major aims. One aim is to provide education to providers and to health education students so that they will have the necessary tools to bring culturally competent information and education as they prepare to work with their patients, as well as harnessing the resources of the community so that our community members will be more aware and they'll have more information as to the necessary tools that they need to prevent unnecessary limb loss. We are so happy for the relationships that we've built through the vascular department at Jefferson as well as Temple, and for the work that we've done with Save Your Souls and the work with our Abington team. We look forward to this opportunity. We look forward to the work of the Jefferson Collaborative for Health Equity and all of the work that we're doing with both health systems. Thank you very much.
So I represent Save Your Souls. It's a grassroots organization started about 10 years ago to try to reduce amputations in North and West Philly. North and West Philly have a high amputation rate. We discovered that through the use of the state inpatient database, right? So when you guys are done with a chart, that chart all goes downstairs into medical records and they do all this fancy coding and abstracting, and it gets into a database, and you can access that database as a researcher. And you can pull out all the cases where amputations occurred. And that's what we did. We basically analyzed amputations in the Delaware Valley by zip code and found out that there were certain zip codes with really high amputations. 1932, where we sit today, is one of the zip codes with a high amputation rate. 30 people lost a limb to diabetes last year in this zip code. It was 45 amputations, 30 patients, 10 had gangrene on presentation. So that's a really high number. So if you compare it to 19001, where I live and practice, Abington, outside the city, much less diversity, higher median household income. So in 2021, there was 5 patients who suffered an amputation. So 5 up there, which is about, by car, it's 5 miles away, and 30 here. So, and that's typical of the difference between a high income area and a low income area. If you look at some of the big papers on racial disparity and economic disparity, you'll always find that low income, high amputations, high income, low amputations. So I've started doing that research a while back. We tried to organize a program, and that's resulted in what we call Save Your Souls. We do a lot of health screenings, and basically we started out with trying to raise awareness in the Black community. We went to a lot of Black churches, worked at there's a Black Nursing Association, a couple of sororities. We tried to raise awareness. We've been raising awareness for a while, and now we're kind of trying to concentrate on increasing screening. So we're offering screenings to a lot of the locations around here, churches, health fairs, things like that, but we're also offering them to primary cares. The primary cares in this area are probably overworked. They really don't want to do the ABI screenings. They don't get reimbursed. It's just too busy. They got so much else going on. So we figured we'll do it for them. So we're looking for volunteers, and then you guys appeared. So we're going to train you guys to do ABIs and try to do a PAD assessment. Basically, we start out with a little form, which is a standard PAD assessment form, asks for risk factors. If the patient has risk factors, we say, oh, you should have an ABI test. And then if the ABI test is a little bit off or a little bit abnormal, then you get them to their primary care or their hospital for a real vascular workup. So that's the whole idea of today, trying to get you guys to understand what an ABI is, I'm just going to show you a couple quick statistics just so you have an idea why we're doing this. So this just shows the diabetes prevalence in Philadelphia. You can see that some of the areas, 22%, that's really high diabetes, right? The national average is around 10%. Abington, where we live, it's 8%. In this area, it's 22%. So 22% of the people have diabetes. And this is a graph. The darker colors are the high amputation rates. You kind of can see a little bit that it compares where the diabetes is where the amputations occur, which is not unusual. So this is just the number of amputations by zip code. All right, this is 191001 where I practice, where Dr. Marcelin practices. Higher income area. You can see the numbers are always pretty low. And then you can see the two other zip codes, 19132, which is where we stand today. That is the kind of orangey line. You can see that's higher. And then 19144, which is the zip code just down this way. Again, it's a low income area and has higher amputations. Again, we did this through the state inpatient database. This is more data that shows that black men have the highest amputation rate. Black females are a little bit lower. Hispanic males are increasing. I tend not to report Hispanic males when you're looking at small areas like Philadelphia. It's important to go through the database chart by chart or case by case, because you'll find a lot of areas, they will not report race, right? Around Temple, people will not report race. And they do that, or ethnicity, they will not report it. Because that's how it's recorded by the clerk when you're admitted, right? They say, are you Hispanic? Are you, they ask. If the patient refuses, they get a blank. And I'll show you that a little bit later if I can. So what I'm saying is Hispanics, are, because of the immigration things and what is it called, ICE, they tend not to want to tell anybody they're Hispanic. So those numbers, the statisticians tell me that those numbers, we should not report them in Philadelphia because they don't think the population is giving us good data. So this is just my favorite slide. It's amputations in the Delaware Valley, 1990 to 2018. You can see men are always at the top, women at the bottom. And the gap is actually getting wider between us for reasons we don't understand. But women are doing well. They're improving in terms of amputation prevention. Women are doing great. Men are kind of staying the same. What's interesting about this, and remember this, in Japan, it looks the same way. In Italy, it looks the same way. In England, it looks the same way. Men always have a higher amputation rate than women. In all the countries you can get good data from, it's always the same. Why? I don't know, but that's the way it is. So most of the studies on amputation rates in the United States are done through the National Inpatient Sample. It's a sample of hospitals all around the country. Usually it's supposed to be 20% of the hospitals. It's about 16 million admissions. It looks something like this. So I pulled out just the major amputations from 19132, this zip code, right? And so you can see, just so you can see some of the diagnoses, right? Type 2 diabetes, peripheral angiopathy with gangrene, atherosclerosis with gangrene, bilateral legs. So you can just see all the gangrene that shows up. And that's the problem in this area, right? They show up much too late with severe complications, severe gangrene, and there's not much you can do to prevent the amputation from occurring once that happens. So I just wanted you to see some of the diagnoses. And having said this, you can see a lot of them are diabetic, right? Not any surprise there. A lot of them are dehiscence of an amputation stump, right? So they have an amputation, and then for whatever reason they're lost to follow-up, or they come back and have to have a higher level of amputations. Remember, I said 30 people suffered an amputation, but there were 45 major amputations. So a lot of times they're going below knee and then they're being converted to above knee. So anyway, I just wanted you to see this is how interesting the database looks. It's all numbers. I put those words in there. Everything else is just numbers, so it's very hard to work with, but a lot of fun when you really understand it. Important, one last point, I did ask for students who want to help with data analysis. If any, you can reach out to me. My number's on that little pamphlet. We do need one or two more students. Great ideas for research if you're into research. The main one, I was just telling Paul, the biggest study that did, and the biggest and latest study out of a national inpatient sample that looked at amputation numbers and rates, counted, I believe, my hypothesis is they counted amputations wrong. And there's a lot to that, but so that's one idea of why there needs to be another big paper. And then also we've been looking at in the Delaware Valley 155 patients who suffered a full leg amputation did not have any prior hospitalizations. So we're looking into those 155. That's a pretty big number for the Delaware Valley. Why would they not have any hospitalizations prior to that major event in their life? We would think somebody would have diagnosed it and tried to intervene earlier, but So great ideas for research. Reach out to me if you want to participate. Thanks.
My name is Frank Schmieder. I am a faculty at Temple University and a vascular surgeon in practice for some 30 years. We unfortunately face a real epidemic of amputations, and I believe that many of those actually are preventable. We are here today to start steps to identify patients in whom those amputations could be preventable, and performing an ankle brachial index is probably one of the most important first steps. You have gone through the training here and realize how to do these relatively straightforward tests. We identify patients who have abnormal values, and those can be either values below a certain number, or they can be exceeding those numbers, particularly when you have a patient with diabetes and very stiff, very non-compressible vessels. And those patients should be referred back to a primary care physician or to a vascular specialist. It is very important to also realize that anybody who has an open wound, who has changes to the appearance of a foot, say a foot that is rather reddish in appearance or bluish in appearance, need also to immediately seek that consultation. I think if we start at that point and identify those patients and immediately screen them and get them to proper care, that we can make a real difference. The patient groups that are mostly affected and that we're looking for are certainly patients with diabetes, and those are probably the patients at highest risk for amputations, but also folks that have high blood pressure, that have been smoking for a long time, and just folks that have generally pain when they walk, pain even when they sit. Now, once a patient is identified, more testing may be needed. Testing that involves a specific anatomic description and identification of the exact location of the problem. And there are numerous different ways of treating this, from medical treatment, from risk factor modification, all the way to surgical intervention.
Welcome everybody, my name's Paul DiMuzio and I'm a vascular surgeon at Jefferson, and I'm really proud to be part of this multi-institutional effort to decrease that disparate care that Dr. Renzi just spoke to you about. And based on the data that you just saw, you can appreciate that one of the underlying causes to amputations is peripheral vascular disease, and that's what my specialty is in. Our hope is to provide education and screening for citizens of this area to decrease that amputation rate. And part of that education is recognizing what are the risk factors for peripheral vascular disease. Peripheral vascular disease is caused by the disease atherosclerosis. Atherosclerosis is what clogs up the arteries. Favored areas of atherosclerosis are in the carotid artery that feeds your brain, the coronary artery of the heart, and also the peripheral arteries of the leg, and that's what we're speaking about. And the risk factors for peripheral vascular disease / atherosclerosis are diabetes, hypertension, hypercholesterolemia, family history, and maybe most important too is smoking. So there are some areas that we can modify the risk factors, but most importantly is getting that early recognition of someone who's at risk for peripheral vascular disease or actually has it but doesn't know that. Dr. Renzi mentioned that oftentimes peripheral vascular disease is in its early stages without any symptoms, and that's because a clogged artery, if it occurs slow enough, will have the ability to form collaterals around the blocked artery and still preserve blood flow below. It's kind of like Broad Street might have an accident and you can't get through with your car, but you can still get downtown because of 15th Street. But 15th Street is a lot less effective and quick in getting downtown. And eventually, the atherosclerosis can win, completely block off those main arteries, and then you have ischemia, tissue oxygenation goes way down, and the formation of gangrene. So our role here for you is to provide education for the caregivers to recognize peripheral vascular disease such that the screening events, we can direct folks who are at risk for this to the actual screening study, which is the ABI, and that's what we're here today to teach you how to do. So with that, I'll turn the program over to Dr. Marcelin, and he'll go through how to perform the ABI.
So when we're doing an ABI, for today at least, I'm going to be utilizing 3 specific things. I'm going to have my ultrasound gel, my blood pressure cuff, as well as my Doppler. And we're going to use these 3 items collectively to give us all the information that we need to perform the ABI. Now, over here on this board, I do have a quick little cheat sheet, if you will, of what we're trying to do. Basically, if we're going to look for a right ABI, we're finding the highest pressure in the right foot. I'm going to be looking at the dorsalis pedis pressure as well as the posterior tibial pressure. And I'm also going to be looking for the highest pressure in the arm. In this case, we're looking for the brachial artery pressure. One of my colleagues over here mentioned that we could use a stethoscope, and you can. You can use the stethoscope as long as you mark down what those values are, but for today, we're going to use a Doppler because we can actually hear the Doppler. Okay. So what I'm going to do first is, if you can swing around over here, I'm going to apply some of this ultrasound gel. And I just want to listen to make sure we have the brachial artery. So without the blood pressure cuff, I just want to locate the brachial artery and listen to the Doppler sounds. Yep, and then there's a button on the actual, yeah. So we'll turn that on. And for this Doppler, yeah, and then when you turn it on, you'll see the green light.
There we go.
can do is we can lower the volume a little bit. There we go. So we have the brachial artery. I'm going to kind of remember this spot right here. And so now we can put on the blood pressure cuff. And the idea is I put on the blood pressure cuff and I want to occlude the artery so I can't hear it anymore. Okay. And so now we'll deflate this first. And what I want to do is we'll listen to the brachial artery. And we'll try to bring it just a go. Yep. And so what we're going to do is we're going to now puff up the blood pressure cuff. And we keep on going until we can't hear it anymore. All right, so now we keep it there, and then we're going to slowly release until we can hear it once more. And at that point, that's the number we're going to. Okay? So when we get that value, that's going to be what we're going to use for the component for our arm, the brachial artery. Okay? So now we can go ahead and let everything go. And what we're going to do now is we're going to go ahead and find the same, but for the foot. Specifically, we're going to be looking at the dorsalis pedis artery, which is located on the dorsum of the foot, as well as the posterior tibial artery, which is located just behind the medial malleoli. And when we do this value, what we want to do is we want to pick the highest value between the dorsalis pedis or the posterior tibial arteries. So for today's demonstration, I want to first find the dorsalis pedis pulse. So dorsalis pedis pulse is typically found on the top of the foot, close to that first ray, so the first metatarsal bone. So I'm going to put some ultrasound gel on top. And what we can do is we can spread that around a little bit. And something that I like to do when I'm looking for this artery is to kind of go from medial to lateral or lateral to medial, trying to catch that dorsalis pedis artery as it runs vertically along the dorsum of the foot. Okay. So then you can increase. Okay. So now what I'd like to do is go ahead and put the blood pressure cuff along the ankle here. And now we're going to pretty much do the same thing. I'm going to find the pulse, and then I'm going to push up the blood pressure cuff so that it occludes that pulse, and then we're going to slowly release it. And when we start to hear that pulse again, that's the value that we would use for the dorsalis pedis aspect of the ABI. All right. So now you can start to release it. Okay. So now what we're going to do is we're going to move on to the posterior tibial. And like I said before, that's located right behind the medial malleoli. And I'm going to apply some ultrasound gel. And then we're going to search for that again. So we found it, and now we're going to occlude it by pushing up the blood pressure cuff. And then we slowly release. So you can slowly release it. All right, and then when you hear the value again, we make note of that value, and we use that for the posterior tibial aspect of the blood pressure. And so, once again, if you look over here at our board, what I'm basically trying to do is I want to look for a right ABI and a left ABI. And for the right ABI, I would utilize the highest pressure for my right foot, whether it's the dorsalis pedis or the posterior tibial, and I use that as the numerator. And then I can utilize the highest blood pressure, the brachial artery, of either the right or the left, and I use that as the denominator. And when I do that ratio, I get my right ABI. And then I would do the corresponding same thing, but on the left side for the left ABI. And that's how we complete an ABI.
Hi, my question's for Dr. DiMuzio. Why is it that calcification eventually causes the ABI to go above 1.4?
That's a really great question, and it brings up the concept of non-compressible vessels. What can happen in certain populations, such as diabetics, patients with renal failure, and patients who are older, octogenarians, nonagenarians, is that their blood vessels become real stiff. And whether that blood vessel is occluded, meaning, well, stenosed essentially, or wide open, when you perform the ABI, you can't crank up the blood pressure high enough where it takes a falsely elevated amount of blood pressure for the flow to cease. A normal ABI is from 0.95, almost 1, up to about 1.3. In performing the ABI, if you find that the measurement is above 1.3, that suggests that there's stiffening of the arteries, and then you can't report it as something being normal. So if the blood pressure turns out to yield an ABI of, say, 1.7, the ABI basically doesn't say that, oh, they've got great blood flow. It means that they have diseased blood vessels. They may not be occluded, but they're definitely diseased. And I would report that out as being an abnormal study, someone that would merit further investigation. And that further investigation is done in a vascular lab where they no longer look at segmental pressures, but then they look at segmental waveforms, which are not altered by vessel calcification, and then also toe pressures. So that will be seen in this population, but if you are getting non-compressible vessels, you report that as something that should be further investigated. Great question.
Okay. I have a quick follow-up. So would initially the ABI would come down because of mild stenosis, right? And then eventually it would come back up because of severe stenosis and becoming uncompressible. Is there a point where that crosses back through normal and you actually have a falsely normal ABI?
Again, non-compressibility doesn't necessarily mean there is stenosis. As soon as they're non-compressible, we have to look at the waveforms to determine if there is obstruction. But yeah, there's certain degrees. There may be calcified arteries that are partially non-compressible, and that's where you're going to get the 1.4, 1.5 rating. And then there's going to be vessels that are completely calcified, and you have an infinite ABI, meaning you can't crank it, you'll cause patient to have discomfort. As soon as you crank it up above, say, 240, 250, and you still hear the Doppler, just stop. And that's a non-compressible vessel, and that's how you report it out.
So I have a question. In screening these populations, if we, say for example, get a low ABI score, what sort of general recommendations can we give to these patients prior to maybe more invasive type interventions?
Well, what we have done in the past, if it's below 9, we tell them it's a little bit abnormal, and we would tell them that we write it down for them. We have a little form, and we said, you need to take this to your primary care doctor and talk to him about a circulation test. And hopefully that'll follow up. We usually get their phone contact information, try to follow up in a week or so, make sure they went to the primary care and talked to him about, because a lot of it's insurance related and things like that. So they have to talk to the primary care about maybe getting a referral or doing, or talking about getting a circulation test. But we just make them aware that, their circulation may be not ideal, and they should talk to their primary care about, getting a full circulation workup.